Live.
Sure.
Kenny Bramlett is back. Hey, Kenny, good to see you.
Yeah, man.
You're my kind of guest. You know, you walked in here 2 seconds ago. You said, "What do you want to talk about?" I said, "I want to tell you."
Okay.
So I like to keep it live. I know you're between cases.
No trouble. We got plenty of time.
Oh, good, good. So,
You're on a delay hold getting things ready, so we just finished the hip, so we're good.
good. Well, you know, speaking of hip, I have a friend who lives in Memphis, actually.
Right.
Very active guy. Has had his knees replaced. Likes to play tennis. Did well with his knee replacements.
Right.
And then he had his hip replaced.
Right.
And technically everything went well from a surgical standpoint. You know, he healed well. The
It went well.
the prosthesis looks good,
Okay.
but he's had a lot of trouble getting back into his activities, almost with the same pain. And I've seen a couple of patients that have had hip replacement before, and then they don't do well.
Right.
And it seems that he's having like some iliopsoas tendonitis or some iliopsoas bursitis.
Yep.
But now you've got an implant in there, and imaging is virtually impossible.
Correct.
So there's really no way of really clarifying that diagnosis, and I'm, you know, I don't have a good handle on who gets this and what do you do when that happens.
Well, there's a couple options that exist. Because just because you have an implant doesn't mean that the condition of your hip has been rectified, so to speak. Because you have a capsule around the hip, which is like a baseball glove holding a ball. And if it's a really flexible baseball glove, then it's not very tight and fibrous. If the capsule is very fibrous and also pseudo-calcified, that could be a problem. So commonly on the front of the hip, that kind of person, I mean, we've even arthroscopically gone in and done a capsulectomy to relieve that kind of pain.
Even on people who've had hip replacement.
Absolutely, yes, for sure. It's a scar tissue fibrosis after a joint replacement is not really recognized by most people. Like we just did a case a while ago, a guy had it only 3 years ago, who still had pain. He was sent to us, his x-rays look normal, of course he sees a doctor, and x-rays normal. We opened his knee because we knew it would be the case. He has got a rind of scar tissue, you know, like the lining of like the rind of a watermelon. You got the green and you got the white, where you get the red. That rind can be very thick. It can be 3/4 inch thick in a knee. So about 3 to 5% of knee replacements will just scar. That's just characteristic of that person. You can't predict it. And you could go in, sometimes with this clean, fresh, within a year, you can arthroscopically cut it out, and they do fine. You just do a synovectomy.
I mean, I would say the hip replacement was within the last 12 months, for sure.
Sometimes with the hip, the best way to look at that is to inject his hip with lidocaine or Marcaine.
Right.
Give him a big old 20 cc dose of Marcaine intraarticular, because he'll have a capsule, he'll have a pseudo capsule which is formed around the hip.
Okay.
Give him an injection. The pain goes away for 3 days. It comes back. Repeat it. It goes away again for 3 days. It's not a prosthetic problem. It's a soft tissue problem because you're numbing the capsule.
Sure.
So that's how we diagnose that. So then you'd go in and do a capsulectomy or possibly just an arthroscopic scar resection around the hip itself, and that'll resolve that.
But why will it resolve that? I mean, if the problem is scarring, and you go ahead and remove scar, why won't scar come back?
Not common. It's very uncommon to get a secondary major scarring. It's at first find because the initial surgery is very invasive. You know, you got cutting and dissecting and retracting and more bleeding than just a scar resection. So it's not common. The second time
What is
around,
the recovery? Since this is arthroscopic, is that what you said?
it can be arthroscopic, but it depends on what his x-rays look like and how much scar he's got, how much restricted range of motion. Okay, but if it's restricted range of motion, we'd probably make a mini incision and cut it out. If it's good range of motion, but still with pain, and responds to the injections like twice, so there's consistency,
Right.
you can do an arthroscopic.
And how long does it take to recover if you do it mini open, let's say?
2 weeks, 4 weeks.
2 to 4 weeks. Okay.
Before you start doing what you want, you can walk on it immediately. I mean, it's no like this overnight or outpatient kind of thing. But as far as playing sport, you kind of hold them back for about a month.
Okay.
I mean, but the other thing is that you can overlook sometimes, and you see this on your side of the fence commonly, is that they can have a lumbar sacral problem.
Sure.
Which is radiating like a L3
like a radiculopathy. But this is not a radiculopathy.
Right. But I
I'm
was saying,
very certain it's not a
but
radiculopathy.
you do see that.
Absolutely.
We
Absolutely.
see people come to us and they have groin pain with a completely normal X-ray,
Right.
completely normal range of motion. Because with a hip, if you can't, with a normal person who's not had surgery, they should be able to do internal rotation like this. This is internal, that's external.
Right.
The first thing you lose if you have hip disease is the ability to do that.
Sure.
So if you lost internal rotation, you probably are on the stage of hip disease. But if you got normal range of motion and deep groin pain and some sciatic pain as well, then it commonly can be an L2-3-4 radiculopathy.
Absolutely. And I
So-
see that all the time.
Of
I see
course.
that all the time.
But the internal external rotation is the key.
But I've never considered the capsule
Yeah. The
as
capsule
the
is
issue.
an issue. It is an issue.
Never considered
We
it
see-
after a hip
We
replacement.
see it all the time. And
Okay.
some people who have early orthopedic changes, who've lost a little bit of range of motion, but they still have a joint space, we will arthroscopically go clean up their capsule, and the spurs are in that acetabulum, and they usually have a degenerative labrum, like somebody has a degenerative meniscus in rheumatoid arthritis, and do a partial labral debridement and a partial capsule section, and that also allows them 3, 4, 5 years.
Since we're still on hip, when I was coming over here, a friend of mine texted me, and she said, I got this friend who's having pain on the side of the hip,
Right.
a burning pain, and it's intermittent, and doesn't know what it is.
Okay.
So, anyway, something came to my mind as far as what that was, but I'll let you sort of discuss that a little bit.
Well, the 3 most obvious things, 3 or 4 most obvious things you're going to see is the most common is going to be trochanteric bursitis.
Right.
And you get trochanteric bursitis right on the hip bone, that the one that sticks out by your pocket, and that usually is the gluteus medius minimus tendon, which attaches there, and that actually more like a rotator cuff tear,
Right.
because it goes on for 3 months, 6 months, and injections give it relief, but it comes back again. Then usually that muscle can be torn off or braided off.
This was described more as burning pain on the lateral aspect of the thigh.
It's lateral pain. It can be very rare. It's piriformis syndrome.
Right.
It can be impossible because it'll radiate pain down the side of the leg. It can be iliotibial band syndrome.
Mhm.
It's a tight iliotibial band secondary to the gluteus medius minimus trochanteric bursitis. And last of all, it can be the early stages of a prodrominal radiculopathy from your spine.
One of the things that was coming through to me was this meralgia paresthetica.
Okay.
What are your thoughts on entrapment of the lateral femoral cutaneous nerve? This gentleman was described as overweight.
If you're a protuberant kind of guy with a big paniculus, it can be that. But as far as me picking up on that and making a real accurate diagnosis, that's a hard diagnosis.
And yeah, it's a diagnosis of exclusion.
Everything
I
else
like to
being
say.
gone,
Yeah,
it might be number 5 or 6.
Yeah, you have to exclude everything else. Absolutely.
For sure.
All right. Shoulder. Let's move on to shoulder.
Perfect.
I know you love shoulder, so
Yeah, we do lots of them.
so-
It's a great disease.
Um,
Because you fix it.
I wish I brought my X-rays of my shoulder,
Yeah.
but I'm a throwing. I play a lot of tennis,
Sure.
a lot of racket sports, and just on X-ray, there's just a huge difference between what this shoulder looks like
Sure.
on X-ray and what this shoulder looks like on
Okay.
X-ray. This shoulder, my left shoulder, looks totally clean, like a 20-year-old shoulder. In this shoulder on X-ray, you can see like a moth-eaten appearance in my
On the tuberosity.
on the tuberosity. Absolutely.
That is because, here's what happens. So your acromion is this bone right here. So as you overhead throw, and you usually are out, you come across most of the time. You're coming across. So when you come across the humeral head under there, and you have an acromion, by you pulling on your acromion all your career, your deltoid pulls and gradually develop somewhat of a stalactite, a descending spur,
Mhm.
and it'll start curling down as you get over. So when your humeral head is younger, you got freedom of motion. As you get older, this anterior acromion will spur down from fibrosis, micro tear, calcification. So it'll just like a slow stalactite. So rather than being flat, it'll stalactite down. So when you raise up, you're okay, but when you come across or abduction rotate, you'll rub it.
Mhm.
And so the common problems are difficulty sleeping at night. That's when it's symptomatic enough that something's wrong.
Sure.
Trouble taking off a shirt like this.
Mhm.
Terrible. Okay? Hard to shampoo your hair, comb your hair, things of that nature. And reaching the seatbelt. because that's a reach motion like this, or even back in your passenger chair, you know. So those are the 4 things that we see. 85% of everybody has them. And if it's more than 6 months and you can't sleep at night, positionally, shirt, painful, seatbelt, hair, you're headed towards impingement syndrome. It's nothing more than the spur irritation because you're abraded. Sometimes it's okay, but sometimes it just bites you. So all you do is shave that off, and then you're free. If you catch it early, before the head rotates with a rotator cuff on it, there's 4 muscles on top. If you catch it before it's early, then your tear is nothing. You're just taking off the spur and a calcified CA ligament, which is also a brachial ligament on the front. Easy. That's a 15-minute operation. They go home out of a sling the next morning. Go back. We do those usually like on, you know, so it's outpatient. Do them on Friday, back on Monday. Go to work on Monday.
I have a feeling there's a lot more going on in my shoulder than that.
Well, what happens is, if it rubs a lot, that's number 1. Then that's abrasion. Now, if it's long term and you're a long term overhead thrower, then what you have is secondary biceps abrasion under the rotator cuff and the labrum from shifting arm position, backhand, forehand, and extended reach. You'll aggravate and tear the labrum, which is the rim of the glenoid.
Right.
Which that's an easy fix too, generally speaking. That's a couple of anchors and another added 10 minutes of an operation, but it's fixable and you're out of a sling in 24, 48 hours and you can work.
So, I've had those symptoms, but they're very short-lived.
Right.
Maybe it puts me out for a week or 2 weeks, but that's it.
Have you had an MRI?
I have, actually.
What did it say?
Oh, it's been like 6 or 7 years, but it looked terrible.
You should repeat it.
Yeah.
You should repeat it. We've had an MRI and probably showed tendinosis, bicep tendinosis.
Yes, all of that.
Early labral degeneration.
Yes, all of that.
If you're a chronic thrower for 30 years, you've got those findings. But you're better off, you're better off addressing it before it tears open.
Sure.
It's kind of like if you're crawling around in your pants for 3 days, you're going to get threadbare in the front of your pants, right?
Right.
And then you're
But that's in style now, Kenny.
Yeah. Sure. Yeah. It's not the iron.
Right, Corey? That's the style, right?
It's not the iron-on patches we had in the 60s, right? But before it tears, then it's a whole different game of recovery and repair, which is not major, but you can avoid all that. So it's better to
so
fix
hard. It would be so hard, and I'll just put myself in the realm of a patient. Yeah. It would be so hard for me to put myself in that situation when I'm so functional. But it's preventative is really what you're saying.
Right. I mean, because if it rubs, you're thinning down your rotator cuff.
Absolutely.
And so at one point, you're going to do one big whack of something, and then it's going to go from, like a kid who's worn his pants thin or threadbare, when you squat down your jeans, all of a sudden it makes a big old ripping hole across the whole thing. Well, now you got a whole different ballgame.
Do you think I need contrast in there?
No, you don't need contrast. You just need a straight MRI.
Okay.
Yeah.
All right.
Yeah. I mean, that's an easy thing. Rotator cuffs are easy to fix. They're easy to get over. I mean, what we do with them, we do them with a laser most of the time. We debride the labrum and also clean up the bone spur, and then we shave it down. And a rotator cuff itself, it's just repairing. It's like repairing the pocket of a baseball glove. Put some new strings in it, put some oil on it, clean it up, tighten it up, so that you want it to be nice and firm, not tearing open gradually. And you can have a small tear and be totally functional, but hurt. But you're not to that point. You probably degeneration without the split.
Right.
Because if you have, again, classic. I tell our internists and primary care guys all the time, if they can't sleep at night, if they can't take off the shirt sideways or cross arms,
right.
They can't reach your seatbelt without just wincing, then
like I feel restriction doing that, but again,
it's just you just got early spurring and some labral degeneration.
I'm gonna have to give you those images though for our next doc talk.
Let's do it.
You got to get us into the OR too. We got to do that.
Good one.
You got to show us some real surgery.
Nah, I'll be on it.
All right. Anything else, Corey, on there?
Not at this moment.
We good?
Yes, sir.
All right. I'm gonna call it there. Kenny, I appreciate your
Yeah,
time.
absolutely.
I know you got to get back to the OR.
We're next up, but that's all right. I appreciate you coming by. Like I said, anytime we can give people information, decent information, it's good like that.
Yeah. How do people get a hold of you? What's your website? Bramlett Orthopedics.
Bramlett Orthopedics. There, we are you know, my office, I had office in the same place for like 15 years. It's 783-5900.
Perfect.
Yeah.
Perfect.
So
Well,
if we make appointments.
what you got? What you got, Corey? You're gonna read upside down?
Yeah.
Okay.
Becky Holland.
Yep.
She said Dr. Goodman.
She happened about the side of the hip,
Yes,
right?
yes.
We covered it, so you'll have to go back, Becky, and re-review it. But we talked about the hip bursitis, greater trochanteric bursitis, and the tensor fasciae lata as possibilities. So I did cover that earlier. But Becky, yes, thank you for coming in on that. Okay. Can we stop there, Corey? We good? All right.
Thanks a lot.
Appreciate it.
Yeah.
Enjoyed it.
Okay. I'll get with you. Let me. We have a new